Hi everyone and welcome to our module on testicular tumors. The testicles are the male equivalent of the ovaries in the female, and if you know this, it should be easy to understand that testicular malignancies share many similarities with ovarian malignancies. There are a number of tumors that occur in both the testicles and the ovaries. A key difference, however, is that in the testicles there are no common epithelial cancers. Epithelial cancers of the testicles are incredibly rare. This makes testicular malignancies easier to understand compared with ovarian cancers, because in the testicles there are really just two main categories of tumors. There are germ cell tumors and sex cord stromal tumors. Testicular tumors are usually divided into two broad categories. The first category is the germ cell tumors, and these can be further subdivided into seminomas and non-seminomas. As we'll see in a minute, seminomas are far and away the most common tumor of the testicle. The non-seminomas are all the types of tumors I've listed here: embryonal carcinoma, yolk sac tumors, choriocarcinoma, and teratoma. The other broad category of testicular tumors are the non-germ cell tumors, and these include tumors of the Leydig cells, the Sertoli cells, and also lymphoma, which we'll talk about at the end of this video. All testicular tumors, no matter the type, share some common features you should be aware of. First of all, most of these tumors present as a painless testicular mass. In addition, there's a bedside test you can do when evaluating a testicular mass that involves shining a light into the mass. Testicular tumors are solid, so they will not transilluminate, and this is in contrast to cysts of the testicles, which are relatively common. If you shine a light into a cyst, it will fill with light. That's called transillumination. These tumors are often evaluated with ultrasound. That's often the first test that is done. And if cancer is suspected, usually the testicle is removed. This is a surgery called an orchiectomy. Usually these masses are not biopsied, and that's because there's a risk of the tumor seeding either into the scrotum or into the inguinal node. So if a mass is detected and it's thought to be cancerous, usually the testicle is just removed. Let's start by talking about germ cell tumors, which are the most common type of testicular malignancy. 95% of testicular cancers are germ cell tumors. And these tumors usually occur in young men about 15 to 34 years of age. So the classic presentation of testicular cancer is a young man with a mass in the testicle that does not transilluminate. That is most likely a germ cell tumor. There are some key risk factors for these cancers that you should be aware of for your boards. The first one is cryptorchidism, which is undescended testes. Any male who was born with undescended testes, even if the testes were corrected and pulled down into the scrotum surgically, is at increased risk for germ cell tumors. And then second is Klinefelter syndrome, which I talk about in the genetics section. This is a sex chromosome disorder where males become very tall and have a unicoid body shape. This is a picture of a man with Klinefelter syndrome on the slide here. Men with Klinefelter syndrome are at increased risk of germ cell tumors as well. Germ cell tumors are always malignant, and by this I mean they are capable of metastasis, even though they may be discovered at an early stage when the tumor is confined to the testicle. These tumors are often a mix of subtypes. So in the next few slides, I'll go through all the different subtypes of germ cell tumors, but many times more than one subtype of tumor is found in a particular individual. In general, the germ cell tumors are highly curable, and the 5-year survival rate is about 95%. Let's start by talking about seminomas, which are the most common germ cell tumor found in the testicles, and these are identical to the dysgerminoma tumors found in the ovaries in females. This is a big picture of an ovary on the screen here to remind you of that fact. The main difference clinically is that seminomas are much more common. They're the most common type of tumor in the testicles, whereas a dysgerminoma is a relatively rare type of ovarian cancer. On gross pathology, seminomas are a homogeneous mass that are gray-white appearing with no hemorrhage or necrosis. This is a picture of one shown on the screen here. And the clinical presentation of a painless mass that does not transilluminate light should make sense to you. These masses are solid and homogeneous, so they do not transilluminate light, and there's no hemorrhage or necrosis, so therefore there's no inflammation, and that makes it a painless mass. These tumors sometimes produce beta-HCG. This is a tumor marker in 15% of cases. That's because in these cases, the germ cells develop into syncytia trophoblast tissue, and that produces beta-HCG. The tumor cells also sometimes make a substance called placental alkaline phosphatase. This was an older marker that used to be used to try to identify seminomas, but it has poor sensitivity and it's not used much in the modern era. And then finally, seminomas are famous for being among the most curable solid tumors, so they are treated with surgery and sometimes chemo and radiation if they've spread to the lymph nodes or elsewhere, but in general they are highly curable and famous for being a very treatable form of solid cancer. Under the microscope, the histology of seminoma involves undifferentiated germ cells. This is an example shown on the screen here. What you typically see are nests of large cells with clear cytoplasm. Usually the nuclei is in the center of the cell, and because the nuclei is in the center of the cell surrounded by clear cytoplasm, The classic description is to say that these cells have a fried egg appearance. Moving on, let's talk about the non-seminoma germ cell tumors. The first one we'll discuss is called an embryonal carcinoma. This is also a germ cell tumor like seminoma, but it has different characteristics when you examine it under the microscope. Usually this occurs as a component of a mixed tumor. A pure embryonal carcinoma is rare. It occurs in only 2% of all testicular germ cell tumors. And the key distinctions between an embryonal carcinoma and a seminoma that you want to remember is that embryonal carcinoma is a hemorrhagic mass. It usually has hemorrhage and necrosis, and this makes it painful as opposed to the usually painless mass that you see in a male with a seminoma. And just like seminomas, embryonal carcinomas may have syncytial trophoblast tissue, so they sometimes secrete beta-HCG. Our next germ cell tumor is called a yolk sac tumor, also called an endodermal sinus tumor. This is the most common germ cell tumor in very young children less than 3 years of age. It derives from extraembryonic yolk sac cells. So at the bottom of the screen is a picture of the early embryo where the yolk sac forms. Extraembryonic yolk sac cells, meaning yolk sac cells that are not part of the embryo, develop into yolk sac tumors. These are very similar to endodermal sinuses of the yolk sac in rats. That's why they're sometimes called an endodermal sinus tumor. And the main thing you want to know about yolk sac tumors is that they secrete alpha-fetoprotein. AFP normally derives from the yolk sac, and so these tumors make lots of AFP. The other thing you always want to remember about yolk sac tumors is that the histologic hallmark is the presence of a Schiller-Duval body. This is one shown on the screen here. There's a capillary in the center here, and it's surrounded by cancer cells. This is called a Schiller-Duval body. It's present in about half of yolk sac tumors, and it's pathognomonic for those tumors. These bodies are described as glomerular-like structures or glomeruloid because they share some similarities with the capillaries in the glomerulus. And our last germ cell tumor is a choriocarcinoma, which is a rare malignant gestational neoplasm. I talk about these in detail in the video on gestational tumors. They often develop in the female following a normal or a molar pregnancy, but they can also rarely occur in the testes or ovaries. Remember, the testes and ovaries contain germ cells, which can develop into all the tissues present during gestation, including abnormal tissue types like choriocarcinoma. What you see under the microscope are syncytial trophoblast and cytotrophoblast cells, but no formation of chorionic villi as these tissues usually form in a normal pregnancy. The other thing you always want to remember about choriocarcinomas is that they secrete HCG, and this should make sense to you since they derive from the same cells that normally are found in the placenta, and high levels of HCG are useful for diagnosis of choriocarcinoma. The other thing you want to remember about HCG is that it has two subunits, an alpha subunit and a beta subunit. The alpha subunit of HCG is the same as the alpha subunit of LH and FSH, and it's also the same as the alpha subunit of TSH. This means that when HCG levels get high, they can potentially stimulate LH and TSH receptors. In a male who has choriocarcinoma of the testicle, this can potentially cause gynecomastia. HCG can stimulate Leydig cells, which have some aromatase activity, and then androgens in the male can be converted to estrogens, and this can cause gynecomastia. In addition, high levels of HCG can potentially cause hyperthyroidism. This is because the HCG can mimic TSH. A pure choriocarcinoma is the most aggressive form of germ cell tumor, and it may not cause a palpable testicular mass. It's famous for aggressive hematogenous spread, so it's often present in the lungs, liver, and bone at diagnosis. So how this will present is someone with diffuse metastasis and a high level of HCG. That person may have a choriocarcinoma in the testicles that was not evident as a palpable mass. And this type of choriocarcinoma is more difficult to treat and cure than the placental versions of these tumors. There is a teratoma that can form in the testes, and just like teratoma in the ovaries, these tumors contain cells from all three germ layers. So they may have ectoderm cells like skin or hair follicles, they may have endoderm cells like the cells of the GI epithelium, and they may have mesoderm cells like cartilage. They present as a large mass, and on gross pathology there's evidence of neural tissue, muscle, cartilage, and other cell types from all three germ layers. They often occur as part of a mixed tumor in adults with other subtypes of germ cell cancers. Pure teratoma sometimes presents in children, and it tends to present in very young children. The mean age is 20 months, and it usually occurs before the age of 4 years old. A final word on the germ cell tumors. They are clinically divided into two categories. Seminomas, which are the most common form of germ cell tumor, remain localized for a long time. 70% are identified in stage 1, meaning identified when they are confined to the testicles with no metastases. And this is why these types of tumors, which are the most common germ cell tumor, are usually picked up as a painless testicular mass. They metastasize to the lymph nodes first, and they spread hematogenously later if they are left untreated. Non-seminomas, in contrast, tend to metastasize earlier, and they often spread hematogenously, and this is a distinction from seminomas. And then I mentioned this before, but I just want to emphasize this point. Many testicular germ cell tumors are a mix of subtypes. These are called mixed germ cell tumors. So for example, teratomas often occur together with embryonal carcinomas and yolk sac tumors. Seminomas and embryonal carcinomas often go together, and also embryonal carcinomas are sometimes found with just a teratoma. In general, the prognosis is usually worse for a mixed tumor compared to a pure germ cell tumor. And as I mentioned in the beginning of this video, usually when a mass is detected, the whole testicle is removed. And then when it's examined under the microscope by a pathologist, they find out that some portions of the mass are a yolk sac tumor and some portions are a teratoma, and then it's called a mixed germ cell tumor. Next, let's talk about the non-germ cell tumors of the testicles. These are all very rare. The first one we'll discuss is called a Leydig cell tumor. What you want to remember about these tumors is that they can produce androgens and estrogens. This means that in a male, they can cause gynecomastia. The estrogens can cause breast growth. In addition, if they occur in a male who has not yet entered puberty, they can cause sexual precocity, which is early puberty. That's because of the androgen production. On gross pathology, they look like a golden brown mass. That's because they have a high lipid content, because they use lots of cholesterol to make all these cholesterol derivatives that are androgens and estrogens. In addition, the classic histopathology finding is the presence of Ranke crystals in the cytoplasm of tumor cells. On the left side of the screen is a gross picture of a Leydig cell tumor. You can see that it's got a golden brown color. That's because it's full of cholesterol being used to synthesize steroid hormones. On the right side of the screen is a biopsy, and these structures right here are the Ranke crystals that are seen in Leydig cell tumors. Next, let's talk about Sertoli cell tumors of the testicles. These are also sometimes called androblastomas. In contrast to Leydig cell tumors, Sertoli cell tumors usually do not produce hormones, and most of them are benign. These are relatively boring tumors of the testicles, and they're very rare. If they ask you a question about this type of tumor on the Step 1 exam, it's likely going to be to ask you where the Sertoli cells are normally found. So just by way of review, this is a seminiferous tubule here. The Sertoli cells are found along the edges of the seminiferous tubule. They form the blood-testis barrier. In contrast, the Leydig cells are found outside of the seminiferous tubules. Let's talk about testicular lymphoma. Non-Hodgkin lymphoma may involve the testes. The diffuse large B-cell subtype is the most common, and I talk about non-Hodgkin lymphoma in detail in a video in the hematology section. But the reason I'm talking about it here is because it turns out that 5% of testicular cancers are lymphomas. So these don't arise in the testes, they arise somewhere else in the body, but the patient is unable to detect the mass because maybe it's in their abdomen or in their chest. But when it reaches the testicles, then a palpable mass is found, and that's what brings the patient to medical attention. And in fact, this is the most common testicular tumor in men over 60 years old. So in a board question, an older man who presents with a testicular mass may not have a problem arising from the testicles. That man may actually have a non-Hodgkin lymphoma, and testicular mass is a common presenting complaint because it's easy to palpate on examination. Finally, let me mention extragonadal germ cell tumors. So it turns out that sometimes germ cell tumors occur outside of the gonads, meaning outside of the testes or ovaries. These are called extragonadal. They can occur in males or females, and they tend to occur in midline locations. So in adults, the anterior mediastinum is the most common location. In children, they occur in the sacrococcygeal area, which is at the lower back, or intracranially. There are many different subtypes, seminomas, dysgerminomas, teratomas. They're unlikely to ask you about this on your exam, but what they're going to want you to know for Step 1 is that the reason these germ cell tumors occur outside of the gonads is because there's a failure of germ cell migration during early embryology. Remember that the germ cells migrate to the gonads as the embryo is developing. If for any reason germ cells get stuck in an extragonadal location, that can lead to an extragonadal germ cell tumor, and that's the most important thing to know about these for your Step 1 exam. And that concludes our video on testicular cancer.